welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
First presenter will be Eliana Selin. She's currently a PGY2 emergency medicine resident at Boston Medical Center, and today she will be presenting a journal club on the optimal dose of intranasal midazolam for procedural sedation in children.
I just want to state that I have no financial or other conflicts of interest to disclose related to this presentation. As for the background, starting off with routes of administration in pediatrics. So obviously we have the same routes of administration available in our pediatric patients as in our adult patients, but there are some caveats to consider when it comes to this. Intravenous medication delivery and just access to intravenous route is often more difficult in our pediatric patients due to their smaller vasculature or just fussiness of the patients in the clinical scenario. And there's actually been some studies that have shown that IV administration of medications in pediatrics is associated with delays in care, parenteral dissatisfaction, and patient distress. We also have the oral option available for patients, but obviously in the emergency setting, this isn't optimal as it doesn't increase our levels to the desired level within an appropriate amount of time. Therefore, the intranasal route of administration is often something that we can use for our pediatric patients as being a non-invasive route of administration. And studies have shown that intranasal delivery reduces the need for invasive procedures and improves patient comfort. As for the physiology of intranasal administration of medications, so our subepithelium of our nasal cavity is highly vascularized. And as you can see by the picture and likely your own knowledge, our nasal cavity is very close to our brain and our CNS. So when medications are delivered via the intranasal route, these medications are rapidly absorbed and cross the blood-brain barrier, resulting in high drug concentrations and a rapid increase in those drug levels as well. I also just wanted to note that the maximum volume of administration for intranasal administration is typically 1 ml per nostril. Ideally, this is between 0.2 and 0.5 milliliters, but the maximum you can give is 1 ml. And this is for both our adult and pediatric patients. A little bit of background on the study drug, midazolam. So this is a short-acting benzodiazepine that's typically used in a variety of different clinical scenarios, specifically in the emergency department. We use it for procedural sedation, procedural anxiolysis, seizures, substance withdrawal, agitation, and rapid sequence intubation. A little bit on midazolam pharmacokinetics and how intranasal compares to intravenous and intramuscular. As you can see, onset of action is fairly similar between all three routes. However, intranasal administration does have higher and faster peak at being 3 to 5 minutes compared to our IV route at about 10 minutes and intramuscular at about 15 to 30. I also just want to point out for the duration of action, the little starred. So this will come to play later when I discuss the different procedures and methods of this study, but there have been some PK studies that show that the serum levels of intranasal midazolam remain at about 90% of their peak after 17 minutes after administration. And then also just things to consider when we're dosing midazolam, we want to weigh our risks and our benefits, mainly in this clinical scenario, increasing our effective sedation and anxiolysis while minimizing our side effects, mainly being respiratory depression that we'd be worried about. Some previous literature related to this topic. So first, a 2024 randomized controlled trial looking at intranasal versus buccal and intramuscular midazolam in patients with seizures. So basically the take home that I wanted to get out of this study was that even in this disease state where we need patients to have the medication work, they found that there was no difference in efficacy between the different routes of administration, including intranasal. And intranasal midazolam did score highest among caregiver satisfaction as well. Moving forward to a systematic review in 2022 related to our specific patient and clinical population being traumatic lacerations. This was intranasal midazolam. It was a systematic review of various randomized and non-randomized clinical trials, mainly looking at adequate sedation, satisfaction of parents, and then side effects as well. They looked at pediatric patients aged 0 months through 17 years, specifically in the emergency department, requiring sedation for traumatic lacerations. They looked at intranasal midazolam at a variety of different doses used commonly in clinical practice, between 0.2 and 0.5 milligrams per kilogram. And they compared this to oral midazolam, bucomidazolam, intramuscular midazolam, as well as other agents used for anxiolysis and sedation in traumatic lacerations. This study was similar to previous studies where they found no differences in the time from administration of the medication to the start of sedation effects, and also didn't have a difference in side effects as well. And similar to previous studies, intranasal administration did have higher scores for parenteral satisfaction as well. So this study kind of left the question of, well, what is the optimal dose for intranasal midazolam for pediatrics, since they did use a wide range of doses? Which leads us into this study. Again, the optimal dose of intranasal midazolam for procedural sedation. Their primary objective was to identify the optimal dosing of intranasal midazolam for procedural sedation in pediatric patients. It was a prospective, randomized, double-blind, adaptive selection design that was conducted at a single-center children's hospital emergency department. For the exclusion and inclusion criteria for this study, they included patients 6 months through 7 years of age who had a simple laceration, which they defined as being 5 centimeters or less in size, and didn't require any further wound revisions. And it was determined by the attending physician that the child was deemed appropriate for intranasal midazolam. As for their exclusion criteria, they did not include patients with known developmental delays, underlying neurologic anomalies, children with autism spectrum disorders, known diseases associated with chronic pain such as sickle cell, as well as lacerations that included the eyelids, tongue, or intraoral spaces. As for the interventions in this study, they compared 0.2, 0.3, 0.4, and 0.5 milligrams per kilogram of intranasal midazolam, with the maximum dose being 10 milligrams. They used the more concentrated version of midazolam at the 5 milligram per ml concentration, and therefore going back to our maximum volume of administration that we'd want to give to patients, with the 10 milligrams being 1 ml in each nostril. And then on the left is just the atomizer device that they used in this study. As for the primary outcome of this study, they looked at adequate sedation state, which they defined using the Pediatric Sedation State Scale, or PSSS, a score of 2, 3, or 4 for 90% of the procedure. No scores of 0 or 1 were allowed, and the procedure had to start within 17 minutes of administration. And this is where that 17 minutes comes into play that I mentioned during the pharmacokinetics slide for intranasal midazolam. And so they chose this 17 minutes as being a time marker to minimize bias of different procedural lengths, as well as if patients were not able to start their procedure within this 17 minutes, it was deemed a failure of the primary outcome, since the medication should have been at peak effect by this time frame. A little bit about the Pediatric Sedation State Scale. So this is a 6-point scale used to measure procedural sedation effectiveness in children. And in the highlighted box are the scores that they deemed patients to have an adequate sedation. And again, those scores of 0 or 1 were not allowed to be at any point during the duration of the procedure to be adequate sedation. As for our secondary outcomes, they looked at ideal sedation state, which they defined as a PSSS score of 2 or 3 for 100% of the procedure. They looked at time of onset to minimal sedation, adverse events, clinician and caregiver satisfaction using a 5-item Likert scale, and then time to recovery utilizing the simplified Aldrich scale. A little bit about the simplified Aldrich scale. So this is actually a scale that was designed to assess patients recovering from anesthesia in the PACU to determine them appropriate for discharge to the floor And so this is a simplified version. The full Aldrich score goes up to a score of 10, and typically a score of 9 means that patients are appropriately recovered. In this instance, the scale goes up to 8, and the study used a score of 6 to determine that patients were adequately recovered from their intranasal midazolam, and they had to score a 2 in the O2 saturation and respiration columns as well. Getting into our study procedures, so I just want to orient you to this timeline on the left side of the screen, with the top being the varying different things within the study procedure, and along the bottom are our primary and secondary outcomes and when they assessed those outcomes throughout the study procedures. On the left side of the timeline is when all patients who were randomized were supposed to be administered LET, or lidocaine, epinephrine, and tetraphene solution. They recorded patients from before intranasal midazolam administration up until they were discharged from the emergency department, and these videos were reviewed by a blinded outcome assessor for the different primary and secondary outcomes. And again, there is our 17 minutes that they used to determine when the primary outcome was to be assessed. Going into our primary statistical analysis, so they utilized the Levin-Robinson's-Liu sequential selection procedure for their determination of the optimal dose and for elimination of varying doses. It's a bit of a doozy, so just bear with me as I explain it. So on the bottom, I have an example of a hypothetical tally of the patients in this group. It's not actual study data. So basically what they did is they randomized patients in blocks of 4 to one of the 4 predetermined doses, the 0.2 through the 0.5 mg per kg. As you can see down below, it's block 1, block 2, block 3, block 4, block 5. S indicates a success, meaning that the patient achieved adequate sedation. F denotes a failure, or that they did not achieve adequate sedation during their procedure. The outcome difference of 4, meaning that the difference between the dose with the highest amount of successes minus the dose with the lowest amount of successes, was chosen to guarantee a probability of greater than 80% of the correct selection of the optimal dose that would be superior to the others by an odds ratio of 2.25. So as we can see down below, at this point in time after 5 blocks, the 0.5 mg per kg group had 5 successes and the 0.2 mg per group had 1 success. So therefore, at this time, since this is an outcome difference of 4, the 0.2 mg per kg group would be eliminated. After a dose was eliminated, they would continue with randomization now in blocks of 3 to the 3 remaining doses, and so on and so forth, until they either had 1 dose remaining or they randomized 100 patients, which was their randomization threshold. If they could not find a singular dose at the end and they had 2 remaining doses after that randomization threshold of 100 patients, they would then go on to their secondary statistical analysis using their secondary outcomes in a hierarchical fashion. So they ranked their secondary outcomes from 1 to 6, 1 being it was of a higher rank than the other secondary outcomes. So, for example, if they had the 0.4 mg per kg group and the 0.5 mg per kg group left, they would first compare them with the first secondary outcome being ideal sedation state. If one dose was determined to be superior to the others, then that dose would be determined to be superior overall. However, if there was no difference between these 2 doses for this secondary outcome, they would then go on to their second secondary outcome, in this instance, time to onset, and so on and so forth. If eventually they reached the 6th secondary outcome and found no differences between the remaining doses, then it would be determined that none of the remaining doses were superior to the others, and they were both or all to be the optimal dose. Moving into our results section. So overall, they randomized 101 patients to the varying mg per kg doses in their intranasal midazolam administration. As for patient characteristics, the one thing that I wanted to highlight on this slide was the median weight between the mg per kg groups. As you can see, the median and even interquartile range weights for the varying mg per kg doses did not exceed where that maximum dose of 10 milligrams would be. And so the majority of patients in these randomized groups did receive their appropriate mg per kg dosing. As for procedure characteristics, I just wanted to point out that even though these patients were deemed to have minor lacerations, there was a fair amount of patients, specifically in the 0.4 and 0.5 milligram per kilogram groups, who did have penetrations into the subcutaneous fat and the muscle, which in my opinion doesn't necessarily necessitate a minor laceration and could be more painful. And again, like I said on the procedural slide, LET was supposed to be administered to all patients prior to intranasal midazolam administration. However, one patient in the 0.4 mg per kg group and two patients in the 0.5 mg per kg group were not administered LET. However, they were administered lidocaine instead. Moving on to the results for our primary outcome, which again is the elimination of doses that were not determined to be optimal. So after the 19th block of enrollment, the 0.2 milligram per kilogram group was eliminated after it was found to have 9 successes, and the 0.4 milligram per kilogram group was found to have 13. And again, this was a difference of 4, and the 0.2 mg per kg group was eliminated. Then, during the 24th block of enrollment, the 0.3 milligram per kilogram group was eliminated after that outcome difference of 4 was found between the 0.3 milligram per kilogram group and the 0.5 milligram per kilogram group. They eventually then went on and did 29 blocks of enrollment and found that both the 0.4 and 0.5 milligram per kilogram group were left after 101 randomized patients. So they then went on to their secondary statistical analysis utilizing the secondary outcomes and found that there was no difference between all of those secondary outcomes that we saw and looked at before. And again, they didn't report p-values for these either. Therefore, the author's conclusion was that the optimal dose of intranasal midazolam for children undergoing a laceration repair was 0.4 or 0.5 milligrams per kilogram. Some limitations of this study that the authors identified was that they didn't enroll children with developmental delays or autism spectrum disorders, so this is a population that would potentially warrant further investigation into optimal dosing. They didn't enroll children less than 6 months, and then I wanted to add that they also didn't enroll patients greater than 7 years, especially because as patients age and grow, their weight increases, and so this would increase the proportion of patients who weren't necessarily getting their mg per kg dose, and they would instead be achieving that maximum dose of 10 milligrams. And then they did only include those with small laceration repairs. Some limitations that I identified was that it was a small patient population of 101 patients. However, this is a pediatric study, and it's often difficult to obtain large patient populations for our studies. There was also lower than optimal rates of adequate sedation found for the 0.4 and 0.5 milligram per kilogram groups, even though these were determined to be the optimal doses. For the 0.4 milligram per kilogram group, they only found that 65% of patients reached adequate sedation, and it was 70% for the 0.5 mg per kg group. There was also the potential for unintentional unblinding based on volume of administration, since this was not standardized between the groups. As for my conclusions from this study, so when selected for use, intranasal midazolam doses of 0.4 and 0.5 mg per kg provide higher rates of adequate sedation for minor bedside procedures than those lower doses of 0.2 and 0.3, but further studies should be conducted for more complex injuries and procedures with the potential need for more invasive routes of administration in those instances. And I will welcome any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.